everybody. I'm Dr. Sergio Machado. I'm medical physician ophthalmology team, pediatric intensive care from enteral and parenteral nutrition unit from the reference hospital from Uruguay, Pereira Rosell Pediatric Hospital. And me researching team for medical thermography team by Unicare, Burn Unit Service and Pediatric Hospital. Thermography team for rheumatology and thermography team for poison team toxicology unit here. And that's right. We will share information about can thermography monitoring skin burns outcomes. That's the question. How time to important from skin burn outcomes. The potential predictive value of thermography and burn wound assessment was introduced in 1961. Is no anybody working to last years, and the CDC estimated from over a million patients from burns required medical treatment in 2020. Despite the burden injury, there's only 60 burn centers are verified in American College of Surgeons and American Burn Association. The point is the centers only care 25% burns patients, and the remaining rest, 75%, receiving medical care restricted for emergency rooms provided and not especially trained burn measurements. See that the accidents are leading cause death in children after the first year of life. Among these, burns are the frequent cases of morbidity and mortality. Must be occur at home and are the result of is preventable accidents. Now, together, let's generate meaningful real discussions about the amazing opportunities that thermography brings. How that? Also, clinical evaluation and most frequently used method worldwide around the world, and has been shown that accuracy ranges between 50% and 71%, and depends of the experience of the observer. Look at that. Are possible surgical escarectomy guided in real time by thermography? This is one question. But Food and Drugs Administration for US applied and approved laser Doppler scanner. Is the most widely used no-invasive measurements tool for assessment burn wounds. It's the only technique FDA approved. Look at that. The principle of LDA are used low frequency laser patterns for the movement for cells, blood between areas the interest. In Uruguay, is a small country of the South America, we work together for two specialized units for burns. For adult burns patients, National Burn Center, SNAKE, and in Uruguay, from Pediatric Burn Center located in Hospital Pediatrics and College Burn Child Reconstructive Surgery Unit, Unicare. How patients send here between two units? Injuries for compromising at least 20% of the total body surface area, TBSA, and third-degree burns compromising 5% TBSE, and burns involving specialized functional areas, hands, face, genital, joints, and inhalation injuries within Uruguay usually transferred for these units. The second question is, second-degree burn. What is that we don't see? This example, right here one, this example area, second-degree burns is a partial thickness. They are subdivided into A, B, C. This is a classification from Fossati et al. From Uruguay. This old classification. Grade 2A, superficial dermis affected, blisters present, healing without sequelae in 1 week. The bottom of the blister is pink and presents hyperalgesia area. This is figure 106, sorry. Type 2, half of dermis affected. Blister with thick tears, walls, and healing in 2 weeks. It may present anesthetic sequelae mainly on hyperpigmentation. Type 2C, deep dermis affected. The blisters are superficial eschar, revitalized after 2 weeks at expense of dermal remains or skin appendages. You can see an example for the 2 degrees and 3 degrees. And the question is, if you don't have skin, what emissivity can you use it? Because here is no problem. We need dermis, profound dermis, and hypodermis. Yes, and the thermography see three types of histology capes from the skin. But in here, how interpretation for 9.98 emissivity, or how do it perfect emissivity for interpretation? This is a good question. But for us and for the surgeons, it's the middle ground of a partial thickness burns where the diagnostic is difficult to emerge. This is the point. Conservative treatment or remove treatment for prevent eschar and potential healing affected. Because the time for perhaps healing interpretation depends for 3-5 days of clinical optical things. The question is early surgery or not? In Uruguay, the classification from clear area from the pediatrics used Lund and Bronder from the ears on the patients and the different areas for calculating areas for percentage for skin burn. It's a little different for the low or the 9, the Wallace for adult patients. Third-degree burns is a full thickness burns. And again, there are also 3 types, A, B, and C. And A, this is scar that when falling off or after surgical resection, leaves exposed in granulation type suite for grafting. And same time occurs anesthesia and presents the real sign when a hair pulled and outcomes of easily because of follicle damaging. Here is A. 3B presents thick scar and when the falling off leaves exposed fatty tissue. Here, and the rest, C, burn stands on mascal fascia and presents thick scar. And remember, we don't see any capes from the skin. The three questions. Can imaging infrared imaging included in protocols and burn patient managing? If you can, we realize is here point from the signals clinical for calculated burn surface area, burn depth and location area. Why not infrared thermography insert here point in real time and same time? What's opinion of international experience researching? Gannon, Michel Carrière, and the others, we work together the last 20 years about using the validity for thermography for ensurement burn one healing potential. Yes, from the left to right, these researchers analyze day 1, day 4, and day 8 between measurements difference delta T temperatures and healthy skin and burns area. Between difference is perhaps a follow-up perfusion dermis reflecting potential healing follow-up. Because thermography measurements indirectly but excellent specificity of her dermis perfusion reflecting burns death in children. It's amazing. Look at that. Carrière is the last 20 years, more 3 or 4 papers about validity from thermography. And the rest of the world, and if they approve it, use it by LDE, LDA, laser Doppler image. Yes, the laser Doppler image is another tool for measurements, vascular flow, and rise areas for interest. Can use it a point of laser. And this is great limitation because in 5 minutes, we are analyze very small area for the point laser. At the same time, Carrière demonstrated for thermography analyze how big areas in 60 seconds. Yes, this is 1 point. But this is the gold standard. The gold standard is LDA for no-invasive technique for measurements vascular flow. More vascular flow, the first 2 weeks, is the best point for no-invasive techniques treatments, and conservative treatments is only observed. It's low flow in ROI area after the 2 weeks is area the follow-up because it's a difficult and healing recuperation from the first 2 weeks. But here in this work, Carrière analyzed a comparison. The color point is LDA, and the line is at delta T. Look at that. See the point. Good areas from follow vascular blood flow is at temperature are 0.6 delta T. This is the gate for the first 2 weeks. Is a good evolution from this area burn. But if the same areas are negative 2.5, 2.3, sorry, temperatures, and LDA identify poor vascular flow under the skin. and perhaps need early treatment for surgery. Here is amazing. 2 points, 0.6 for good evolution perhaps before 2 weeks, negative 2.3 degrees for delta T is no good evolution. Yes, this is the work from career, but how you do in Uruguay? In Uruguay, we apply at the same time replying this protocol from career, and look at that. We see the same values for intervention, chirurgical intervention. Look at that area, here area, and area more not affected here. And look at the middle, delta T, negative 2.7. Yes. And the surgeon in real time talk. Yes, we got remove area because clinical area is very important from remove that because the scar is very difficult cicatrization, a potential healing. Jaspers from researcher team from Netherlands, it's other work for burns and the last 10 years, sorry. And the same use it, LEDA laser Doppler imaging. The laser Doppler imaging from the left, from the right, and and thermography from the left. This is optical imaging. First, the optical imaging is not only the area for vision seen, and we understood from hyperemia thermal area occult. We do not see them. This area, these margin areas, is secure areas for not remove the skin. But here, it's outside the room for investigating 2 days after the surgery. Laser Doppler image FDA approved. We talk last minutes. The problem is the time to analyze this ground area because it's a point-to-point, sorry, point-to-point areas analyzing and too much time. And what's the problem? The time in the operating room. The healing is not exposed because physiological time is exposing liquid edema, hyperemia area, and is not good for scarectomy. Others, the thermography is a time up, 5 minutes. We analyze ground big areas from one shot. This thermography is statics, but you can use a dynamic thermography. Look at that. In Uruguay, we analyze same protocol for Jaspers, and here we don't use LDA, we use thermography, and they analyze areas compromising from discovery negative 3.2 delta T. This area is need scarectomy from resolve or a necrosis area. What's the problem? There's no applying scarectomy. The potential healing is 21 days. Is the problem is the healing is evolution no for working. And we use another softwares for analyzing reconstruction thermography 3D, and we see the profound of destroyed areas from the dermis, epidermis, and hypodermis. Look at that, real time, and same time with a surgeon team. It's a fantastic software for a promised future of thermography. The team researching from pediatric United Care from Uruguay, we designed a protocol for infrared imaging and by clinical monitoring depth and surface wounds. Yes, look at that. Do you see the picture? Optics area. Thermography area prevents use in same time from areas marked for sclerotomy early. But what's the problem? What's the burn is extended. Look at that. That's an extended wound. Yes. How limitation from thermography? Look at that. Can you see anything? Because out area without skin. And again, how emissivity can use? 90.8? No. 90.5, 90.6, 90.7, I don't know. And now we analyzed imaging thermography, but different emissivity from BTT comparison for referred area and compare for LDA laser Doppler imaging. Okay, we software can use it is a different scales palettes from analyzing areas of interest. And now we are correlate fluid replacement value from diuresis on the first 48 hours and compare for delta T average, perhaps to define a possible marker for severity. We need to find a delta T average value that allows us understand the evolution early potential and propose early surgery. In bedside, no move critical patients are for all medicals, for all students, residents, we defined a thermography. Look at that, the area analyzing by protocol for Carrier, Michel Carrier, we analyze everyone is a low flow area first and analyze comparing every two for blood flow area up and approximately 2, 3, or 5 centimeters maximum for comparison area. Look at that, average negative 3.348. Here, everyone need early surgery because potential healing is low. Other sides. This is the point. This is a big one skin area, but the question is here area are potential healing or we remove all area removed by sclerotomy? No, look at that, conserver, because the delta T is 0.7. Look at that, 0.6 is a higher vascular blood flow. Conserve them, we not remove. These are full thermography analyzed area. But Uruguay. Now we applied a dynamic thermography for guide to hysterectomy and same time, and the role of thermologists combined with questions from specialized through the surgical procedure in real time. Look at that from the low flow areas and limitation areas from the optical vision. Hysterectomy is very strong as remove dead skin from no good front flow vascular. And same time, surgeons ask about Sergio, this area stop or continue? LDA measurements no possible to see the video areas because need reconstructive processor software after 6 hours for remaining. This is one point. Thermography, it's secure because no contact, no radiation. We need for this application, we need a professional sensors for little FOV because need outsiders the area for surgeons. Look at that. This is the other applications on thermography. From decompressive compartment syndrome, in the real time, look, modify vascular area for the hands. It is a fantastic, and the surgeon look at that at a visual TV inside the operating room. Look at the low flow, and for the compressive area, fasciotomy, lateral hand is a good flow. And here we are guided from surgeon again, please, because it's no good flow in the point of the polygon. And see again. No others tools are identify in operating room and other critical areas the vascular point from the bithermography. Pose the challenge into the future. First, possible thermology and specialized working together in real time. See the picture. Can use the emissivity 9.8 skin burns 2-3 degrees. This is ask the questions. And oxidative and humoral stress markers along with imaging, infrared imaging, perhaps needed for others gold standard markers. Thanks so much for everybody. Okay, Professor Marcus Brioski, we talked in him.
Congratulations, Sergio. Sorry for my internet, but very good your presentation. I like so much. You did a review. You studied how to use infrared before to implement. So it was amazing because you had success in the first cases, and for example, when you use 0.98 for emissivity, and you're measuring the delta T, is not so critical if you using 0.95 or 0.98, because you use the delta T and not the absolute value. So maybe we can have some discussion on this point, but when you use delta T, you block the error in both sides, so no, it's not critical, and very good. And there's something that you can implement. Suggestion is in Fear software, you have the function the isotherma.
Yes.
You know, sir, the isotherma. So
Isotherma. Yes.
so for example, you define a region of interest, and you measure on the and you measure sorry and you measure in the region of interest the average temperature, and after this you can establish the above isotherm, or no, the below isotherm. So establish minus 2.3 degrees, and all the and everything on image will be in green, for example. So you measure the average of the region of interest, 10 degrees, for example, and you put all the isotherm below 2.3 degrees below. So everything in green will appear on the image. So it'd be very interesting. So this way, because you will not need to use in future comparing the areas, but you see the green area that is compromised is a tip that you can improve. Also for the other delta T that you didn't show, because on the paper they show that above 0.6 is good to release the patient soon, so you can do the same. And I like so much the video you did showing the perfusion of the fingers, and I believe that during this procedure the surgeon don't see hyperemia, don't see because the skin is so damaged that I believe it's very difficult to the surgeon to understand that it really is doing affect the compression of compartmental syndrome. So congratulations, and I'd like that you comment about the decompression. Thank you so much.
Thanks so much, Professor Marcos Briowski, and very valuable for isothermas. I don't think isothermas is a real from the setup the sensor and set up the temperatures for analyzing point gate 0.6 and negative 2.3. Thanks so much.
Sergio, it was really amazing. You showed this dynamic result in real-time operating room with no harm, with no contact, anything. You just see what we're doing at the time, and the result is so quickly. As Dr. Briosк says, without thermography, you just will see the fingers, but you cannot say at the time if it's okay if you had the result, because you cannot see the hyperemia, you cannot see in the digital figure, the digital image, what's happening, but you can see with the thermography. And even though you showed us that it's possible to analyze during the just after the burn happened, when the patient arrived and the days that follow. So I think you very, very soon we'll have this protocol. Like, okay, in the day one, it happens like this, the temperature like this, and you can do these things. And then when the temperature goes 1 or 2 days like this, you can do that other procedure. And something you showed today, like if it's minus 2.3, it can have a result going to surgery. But if it is more than 0.6, you may not need in that day, you don't need to go to surgery. It can go you can release this patient from the surgery center. Oh, that's amazing. I have a friend in Florida that she worked with wound burn patients for many years, and I'm going to talk to her about this. Very, very great research you bring here. I'm quite emotional with this kind of result. Thank you very much. It's
Thanks so much.
important.
Thanks so much, Dalia. Thanks so much.
Dr. Sergio, congratulations. Not only did you tell us about the value of thermography measuring burn patients, but you visually showed it to us. The pictures and the video, I think, really made your point because we could see in real time exactly how that was being used to analyze and change the direction of how treatment was going and determine if treatment is as effective as we'd like it to be. My question for you is that when we are, one second, when you're measuring delta T,
Yes.
do you control the room temperature at all, or are you just using a point of care protocol and getting the best delta T measurements that you can?
Yes, very good question, Professor Kane. For improved approach in thermography in operating rooms, for us, for thermography, is very nice because the temperature on the operating room is 23, 22 degrees because not improve follow bacterial, virus, and others types. That's the first. Perhaps the humidity is too much low, around 40, 45%. And the other problem is we can up the healings no more, perhaps 25, 20 minutes exposed area because the blood flow from emerging from the depth from outside and the patient from instability and hemodynamic in same time. And anesthesia team see me and why, man, why time to talk to pictures, because the unstable patients depends from the areas, the percentage healings in children's. The room is no problem. The big problem is for me, it's emissivity. Marcus again and talk is a agar node problem, but others and researchers talk about him. Yes, because the dough temperature from the right area is a little bit different if you modify the emissivity. For 9.8, the temperature is very similar from different areas from BTT, but for accuracy for BTT can use in 9.5. This is between difference analyzing for marker. And now the intensive care introducing from different balance for diuresis and balance for hydration, con marker for delta T measurements and different for needed follow in operating room instability markers. The next point is outside the operating room. In outside operating room in point of care units, the temperature of the room between 24.3, 24.5, but the patient standing by stay supine in position very long time, and is difficult from good imaging from resolve the influence of the reflected and infrared areas is not good for the sensors. Humidity in outside room around 60, 65 is too much up, but I think is Glamorgan protocol or AET protocol is but same. Perhaps for need more studies for identify what correlationship delta T values for gate for good for healing, not good for healing.
There's a problem when we present this as a publication, because not a problem, but we must choose to put this on the discussion of the paper. For example, most of the reviewers they will comment that the temperature that you measure on the health skin compared with the burned skin in different stages, the emissivity will be different. So the emissivity of the health skin is not the same of the burned skin, okay? But there's no problem about that, because you must understand, for example, you can use 0.98 for both, and you don't need to correct this. If you explain this on the methods, and you showing that the delta T 2.3 is not a real value considering different emissivities, understand? But you must explain that 2.3 is considering both skins with the same emissivity. It's like a tip, or it's like something to be more practical for the research or in the real life. And so there's no problem if you explain that. But we must understand that the real temperature on the normal skin and the burning skin is not real correct. Understand? But so 2.3 is a way to establish this. But another way to refer is not using degrees, temperature degrees. You can change this with, for example, percentage or a known.
Yeah, understood.
Any unit. Don't put
Yes.
any unit. Just say there's a 2.3 what temperature. No, 2.3 based on that method.
Yes.
You not need to say that it's the Celsius degree, for example.
Understood. Remember we talked any time ago, long time ago, I wouldn't be necessary to define the thermal index. Perhaps the thermal index is more approach from only average temperature, because average temperature is the variable from outsiders and inside variables. The same in Hurricane ask about what's the operating room, or how many people. You could add the picture. How many people inside the operating room? These are best different because very stress and action, respiratory frequency, yes, and emission, air emission. Perhaps one index thermal is the best way from analyzing the future. You know.
And there's another important point is that room temperature. For example, we cannot do the exam in low temperatures and wait so long time because they are these patients, and especially children, they are exposed and they are losing water and temperature, body temperature. They can have hypothermia during this procedure. So the anesthetist must control the room temperature to provide a secure procedure. So we must understand this and not change this.
Yes.
But it's very important that, for example, if you compare, for example, 2.3, but it was done in what's the temperature of the room? Because if the room is more colder, the difference between the high temperature and the low temperature
Too much
will be much
higher.
more. Yeah, yes. But if you do in a room, for example, 24 degrees is the room temperature. It's different. It's so close. Is less.
Yes.
Do you know? They commented on the papers, the room temperature, Sergio, on the both two papers you presented before.
Yes, yes. This is a little different because the papers analyzing in lit and laboratory imaging thermography without five control areas. There's no patient inside the room. Inside the room, I know and see or not sharing for this moment, but it's refer 23 more or less 1 degree.
Okay. But I believe that is a consensus that it was something a bit more than 20 degrees, 23 degrees Celsius. But it's important that you establish with the anesthetist that they control the room temperature and inform you for you to put on the papers
Yes, yes.
that they are put.
It's going
Thanks
to the
so
future.
much.
Yes, yes, going to the future. It's more clear, important to register everything for others medical here. BTT because low BTT move because too much time patients stay low and fluid from exposed areas because you analyze areas and now tap area at the same time for not remove areas for heat from inside from outside because the room is too much cold.
Could be interesting. Sure, you measure the BTT as the highest temperature, like a core temperature, but also the minimal temperature of the nose, and you establish how is the amplitude, how is the window between the highest and the lowest temperature in the body, and if you show to the people or on the papers that you're doing that most of the patients are close independent of the temperature or room temperature, but you establish do you know the thermoregulation of the patient? Understand?
Sympathetic activity, yes, in same time. And
Yeah, this is a way to understand how is working the thermoregulation of that patient during the procedure. There's a 10 degrees difference between the maximum and minimum. Okay. Yeah, that is different when you compare someone that the difference is 5. But I'm saying this is a way if the patient don't have any problem on the brain or on the face, this thing. But considering normal,
yes,
it's very important to put this data.
Other application of thermography, you remember now, because the emotion from the exposed, nurses, we don't stay in by good area for oximeter. And no, this finder is no good, and this finder is no good. And me, high thermography, analyze white finders is good for oximetry. And we need other hands. One finger is good for oximetry and establish here in the same time. Other many applications of thermography.
I was
Elizabeth Villela. Oh, thanks so much, Elizabeth. Ask Elizabeth, please. Elizabeth at anesthesiology. And we talk ever through anesthesiologist control patient temperature, surgery site exposed to environment and heat loss. Yes. We will be great to the coder for Romneys. Yes. That's right, Elizabeth. Thanks so much.
Sergio, maybe it should be useful to have that preparation of the imaging. I forgot the name just now, that we learn, like you take the temperature that it's important to find, and you close this temperature, and then you make the contrast in the body, and only will show the digital imaging and the points where you have to make this correctomy.
Yes.
Did you remember this? Maybe for your
Yes. This is picture and
research?
picture
Yes.
in the sensor, scientific sensors
Yeah.
is a capable for possible for orient, because what's the problem? You using palettes, not a rainbow, because the rainbows confuse others.
Yeah.
No.
Mhm.
This palette can use it in from the surgeon for good for others, not for us. Please
Yes.
remember that. But yes, I don't know. Use it this other for picture in picture. Picture in picture is good because in same time with the optics and
Yes.
right
Yes.
area.
I was thinking about the surgery. Maybe he doesn't know about thermography or how to dimension the area, and picture in picture maybe will help him to follow the
Yeah.
area. Okay, just so to remind.
Okay.
But it's
Thanks
still
so much.
very interesting. So many things that we can bring from this research, né? So many interesting points we can learn
Yes.
about how to use
Yes.
thermography.
This application of thermography in operating room, we sharing information about the surgery. And now, next week, patients, adults, need to talk in the sharing why applying thermography for an adult. The next point is the pediatrics to adult patients. It's very nice because everything ask about why don't see, and no, don't forget why don't see, especially you need see. Yes,
Mhm,
between thermologists and specialties.
Interesting. Are you following up with these patients that went to the operating room?
Yes, this patient is dead
This
because big areas are compromising 80%.
20%.
And you see again other sclerotomy and stabilizing hemodynamic, and we have PCR and not come back.
Okay. But it will be very interesting in those cases that they have less than 6%, for example, because they have more chance to survive.
Yes.
Mhm.
Yes, for the children is very impressive, everything. And
Mhm.
for me personally is very impressive. The ask is no free ground deep areas. The ask is 2 degrees. What's happened?
Mhm.
Remove or not remove? And the next point to the protocols inside researcher, this degrees, 2 degrees depth burn skin.
Okay, so the most important is now to find what happened between 1 and 2 and -2 degrees, because you will be okay. It's not more than 0.6, but it's less than 1. So how would it be? Huh?
Yes.
Yeah. Okay.
And the Unicare unit um, working for LEDA, and we work together, LEDA and thermography in the same time. And
Okay.
the last talk, the medical talked to me, he said, oh man, if you 5 minutes, you analyzing big area, and me a point to point to point in 10 minutes or more for analyze the same area. This is the limitation.
Yeah, that's good.
Okay.
Okay, congratulations.
Thanks so much.
Thank
Thanks so
you
much,
very much.
everybody. Okay. Nice to meet you, and thanks so much for everything. With logistics difficulties, but stay here and follow up.
That
Okay.
was great.
Okay.
Thank you.
Professor Marcos Brioschi, perhaps do you close it?
I think he folded. Yeah, he folded down. I think he's not in again.
Okay, can you close it,
But,
Professor Robert Kane?
yeah.
Yes.
Good. Well, thank you everybody for coming together from all over the world to listen to these presentations, to share of your knowledge, and to really just put this profession that we've all grown to know and love in the forefront, and to see how we can really help people using this technology. So I look forward to next week's presentation. I'm sure it'll be announced shortly. Everybody have a great day, and we'll see you on the next conference.
Bye-bye. Thanks so
Thank
much,
you,
Professor
everyone.
Kane.
Bye-bye.
Thanks,
Thank you, Dr.
everyone.
Robert.
Bye-bye. Bye-bye.
Thank you, Sergio.
Bye. Nice day. Ciao.
Lovely.